All right, hello everyone. My name is Bobby Hedyari. For those of you who don't know me, I'm one of the new CMR readers. I just joined the Stephenson CMR Center last year, and it's really my pleasure today to talk about stress perfusion cardiac MRI. So I'm just going to begin with a brief outline. I'm going to begin by discussing risk stratification 8 years after the landmark COURAGE trial. Next, I'll be discussing stress perfusion CMR, how we actually perform it, the utilization in the acute versus the chronic setting. The majority of my talk is going to focus on high-risk cohorts with suspected coronary artery disease, as some of our standard techniques for assessment of these patients may have limited sensitivity. So what is the diagnostic and prognostic performance of a more novel technology, stress perfusion CMR? And lastly, just a few words about cost effectiveness, particularly in our present economic climate with rising healthcare costs. So beginning with the review of COURAGE 8 years after its publication, COURAGE, for those of you who are unfamiliar with it, was really a landmark trial in the field of cardiology. And so much so because it challenged our conventional thinking about the management of patients with stable coronary artery disease. COURAGE randomized over 2,200 patients who had stable coronary disease, which included those patients with CCS class 4 angina who had stabilization of their chest pain, to an initial treatment strategy of optimal medical therapy versus OMT plus revascularization. And very surprisingly, the primary endpoint of survival from death and myocardial infarction was actually not different between medical therapy versus revascularization. Indeed, there was actually no hard endpoint in COURAGE that showed a reduction of events for revascularization versus medical therapy. And although at the time the results of COURAGE were quite surprising, perhaps in retrospect they should not have been as surprising, because prior to the publishing of COURAGE, there had actually been 7 trials that had failed to find any difference in mortality or recurrent non-fatal myocardial infarction for patients undergoing revascularization. And so since the COURAGE trial, our understanding of coronary artery disease and its assessment and management has really evolved beyond luminography. Of course, with catheterization, we are assessing for obstructive epicardial stenosis, but we know that even in regions where there is no significant epicardial stenosis, there may be a substantial amount of positive remodeling and plaque formation in the lining of the coronary artery. And indeed, the majority of heart events, cardiac death and acute myocardial infarction, are due to plaque rupture from non-obstructive lesions, the so-called vulnerable plaques. In addition, in areas where there's a significant epicardial stenosis, you may have no downstream myocardial ischemia due to collateralization. And in areas where there's not a significant epicardial stenosis, you may have downstream myocardial ischemia due to microvascular dysfunction. We have to remember that with cardiac catheterization, we actually visualize less than 1% of the coronary artery tree. And in fact, all of the smaller arterioles and microvascular circulation is not well visualized. So there can be extensive downstream microvascular dysfunction, even in areas where there's no epicardial stenosis. Finally, just a quick point, we should remember that with revascularization procedures, there is peri-procedural risk, chiefly with bypass surgery or risk of stroke, and of course, with percutaneous coronary intervention, areas that are stented can undergo instant thrombosis or instant restenosis. So what is the importance of visualizing or assessing downstream myocardial ischemia? Well, this is an area of active research. We have older data from Dr. Hakomovich and colleagues from 2003. And he performed a retrospective analysis of over 10,000 patients and identified that perhaps those patients who have more extensive degrees of myocardial ischemia, more than 20% of the myocardium, may actually derive benefit from invasive revascularization versus optimal medical therapy. And interestingly, in those patients who had lesser degrees of ischemia, there may actually be a tendency to harm with revascularization versus optimal medical therapy. And this is the foundation of the ongoing ISCHEMIA trial. This is a multi-center international prospective trial examining an imaging-guided strategy of OMT versus OMT plus revascularization. It's very similar to COURAGE, but the randomization is based on imaging data. Overall, there are 400 research centers worldwide participating in ischemia, with the goal of enrolling over 8,000 patients. And the patients that ischemia is enrolling include those with moderate or severe ischemia by cardiac imaging. And indeed, this data has really been reflected in the latest iteration of the AHA-ACC guidelines, which actually recommend decisions for early coronary angiography and mechanical revascularization should be based chiefly on patient risk. Those patients who are at low risk, less than 1% annual rate of cardiac death, can safely be managed with medical therapy, versus those patients at high risk, greater than 3% annual rate of cardiac death, should have consideration for early coronary angiography, and there remains clinical equipoise in those patients at moderate risk. So this brings us to stress perfusion, or stress CMR, I should say. So stress CMR can be performed with a variety of different techniques. There are some centers actually performing exercise stress CMR using a non-ferromagnetic treadmill or supine bicycle, and this has the significant advantage of providing the hemodynamic data from exercise in addition to the myocardial perfusion imaging. An inotropic agent, dobutamine, may also be utilized for stress CMR. But most commonly, most centers nowadays, due to technical feasibility, are using perfusion imaging. There are various vasodilators that can be used, including adenosine, which is perhaps the most commonly utilized agent that can be administered as an intravenous infusion. Dipyridamole is also used in some centers. And of course, a newer agent, regadenoson, that's available in the United States, can be administered as an intravenous bolus, and no infusion is necessary. So what are some advantages of stress CMR? Well, there are numerous. Stress CMR has both a high temporal and spatial resolution. In fact, the spatial resolution is much higher than that encountered with nuclear perfusion imaging. It has relative operator independence, meaning any sort of imaging plane can be utilized for perfusion imaging. However, you do require an experienced technologist who is capable of performing stress perfusion imaging. It is not limited by adverse body habitus. Particularly in younger patients, you can also assess coronary origins in one study. And it provides a comprehensive assessment of not just myocardial ischemia, but also ventricular function and myocardial viability, all in one study. There's, of course, no radiation exposure with stress CMR, and it has a really excellent safety profile. What are some disadvantages or limitations? Of course, those patients with metallic devices that are not MRI compatible, such as an ICD or cardiac resynchronization therapy device, cannot undergo stress CMR. Patients with significant renal dysfunction are at increased risk of nephrogenic systemic fibrosis, so these patients are also relatively contraindicated. And of course, patients with severe claustrophobia often cannot tolerate stress CMR. Fortunately, all the new pacemakers that are being implanted in Calgary, and I'm sure many centers across Canada and the US, are now MRI compatible, MRI safe. And not only are they safe, but the imaging profile has really improved with these pacemakers. And here we can see an RV lead traversing the tricuspid valve into the RV apex. And actually, we can visualize the area very well with very little artifact. So what is our standard technique for stress CMR? Well, patients are placed into the CMR scanners. Localizers are performed for imaging planes. We then administer a concomitant bolus of our stress agent, either regadenoson or an infusion of adenosine, with our stress CMR contrast agent, gadolinium. We then perform stress perfusion imaging, followed by short axis and radial cardiac function imaging. A second bolus of gadolinium is then administered for rest perfusion imaging. And finally, we perform late gadolinium enhancement imaging or delayed enhancement imaging to characterize myocardial scar. Typically, our imaging planes for 3 short axis, an apical, mid, and basal short axis, are planned off of a 4-chamber, 3-chamber, and 2-chamber views, and that's so we can ensure that we are perpendicular to all of the myocardial walls. And here we see a typical example of our basal slice, our mid short axis slice, and our apical short axis slice. And these segments are arbitrarily divided based on the American Heart Association 16-segment model. And this model can actually be overlaid to create a bullseye of the typical coronary distributions to the myocardium. Here in red, we see the typical distribution of the left anterior descending artery. Here we see the typical distribution in yellow of the left circumflex artery, and here in orange, the typical distribution of the right coronary artery. I use the term typical because, of course, although the majority of patients have a right dominant system where the posterior descending artery is supplied from the right coronary artery, there is some patients who are supplied from the left circumflex artery. So here we see an example of a stress perfusion defect. Our gadolinium bolus shortens our T1 and provides an enhanced signal and intensity as it perfuses the myocardium, and areas that are dark don't experience hyperemia due to reduction in myocardial blood flow. And we can see here that this patient has a really dense, significant myocardial perfusion defect in both the anterior and anteroseptal segments, which is the typical distribution of the left anterior descending artery. One of the significant advantages of stress perfusion imaging is that we can compare our stress perfusion imaging to rest perfusion imaging, which helps us to assess for reversibility, but also, most importantly, for artifacts. We can also compare our stress perfusion imaging to concomitant functional imaging with cine steady-state free precession imaging. And this is also quite helpful because we can assess for areas of myocardial wall thinning and for regional wall motion abnormalities that we can compare to areas of reduced myocardial perfusion. But perhaps the most important comparison is the comparison of our stress perfusion imaging to late gadolinium enhancement imaging. Unlike other modalities such as stress echocardiography and nuclear perfusion imaging, we can actually directly assess myocardial scar and viability through late gadolinium enhancement imaging. And so this allows us to assess the most important parameter of reduced myocardial perfusion, that of inducible ischemia. And the definition of inducible ischemia is essentially areas of reduced myocardial perfusion where there's no substantial late gadolinium enhancement. So that may seem confusing, so I'll just give you an example. On the left here, we have a stress perfusion image, and this may not project very well, but we have a stress perfusion defect both in the inferior segment as well as the lateral, infralateral, and anterolateral segments. And when we compare that to our late gadolinium enhancement corresponding short axis image in this patient, we see that unfortunately this patient has suffered a significant prior inferior myocardial infarction, as shown by this bright area of late gadolinium enhancement. So that's matched to this stress perfusion defect. But in the lateral segments where we see reduced myocardial perfusion, here there's actually no significant late gadolinium enhancement. So this patient has an area of inducible ischemia. And indeed, when this patient went on to have cardiac catheterization, they had a significant lesion of a large obtuse marginal artery that was supplying these lateral segments. So one of the more recent advancements that we've had with stress perfusion imaging is performing stress perfusion imaging here on the left at 3T versus 1.5T. The advantage of 3T is we have a higher signal-to-noise ratio, so qualitatively it's much easier to assess for stress perfusion defects. And this was actually evaluated by Dr. Cheng and colleagues in 61 patients. And here we can see that for the detection of coronary artery disease, the area under the curve was actually improved by 3T versus 1.5T, but in particular for the detection of single vessel disease, which may have a smaller territory, we see a substantial increase of the area under the curve, 0.89 versus 0.7 for 1.5T. And all these 61 patients underwent stress perfusion imaging both at 3 Tesla and at 1.5 Tesla. Another recent advancement that has substantially improved our ability to perform stress perfusion imaging is motion correction. And motion correction allows or is performed with automatic registration and tracking of diaphragmatic movement that allows us to actually control for motion with breathing. So this is actually a scan in a patient who was free breathing. They did not hold their breath throughout the entire perfusion imaging. And we can see here up and down motion with breathing that's actually been corrected through the registration and tracking of diaphragmatic motion. And this has two significant advantages. The first is it markedly improves patient comfort because they no longer have to hold their breath. They can actually free breathe through the perfusion imaging sequence. But more so, it also substantially helps us with quantitative techniques. Oftentimes with quantitative techniques, we actually have to trace both the endocardium and epicardium of all of the phases of the corresponding slice of perfusion imaging. And of course, we have to do this individually when there's a substantial up and down motion of the myocardium. But when there's motion correction, we can actually just automate this process quite a bit, which substantially reduces our post-processing time and allows us to get a much quicker assessment of quantitative measures of myocardial blood flow. And here we see one such example. This is actually a patient who had a normal stress perfusion study, but here we have the 6 segments at the base of this short axis basal slice, and here we see the arterial input function of the gadolinium through the LV cavity, and here we see the 6 segments where we can actually look at the upstroke of signal intensity over time, and this provides us with semi-quantitative measures of myocardial blood flow. So it's quite useful. And you can actually go on to do fully quantitative measures and actually quantitate the absolute myocardial blood flow in each myocardial segment. And here's one example of a patient who had a semi-quantitative assessment of myocardial perfusion. And in the upper left corner here, we see the qualitative stress perfusion imaging, and we see that it appears that this patient has an anterior and anteroseptal stress perfusion defect. And when we actually plot the signal intensity over time, we can see that in the area which is red, which represents the anteroseptal segment as compared to a remote segment, there is a significant difference. And we can use different quantitative measures, such as the peak contrast enhancement in the remote versus the ischemic segment. We can look at the difference in upslope, or an upslope integral, to actually look at the myocardial perfusion reserve when compared to the rest perfusion imaging. And we see here that it's significantly reduced in the ischemic segment versus in the remote segment. Just one moment here, I have to just let someone in. One moment, please.
You can go ahead.
So, sorry, I just had to let in a very important audience member here, Dr. Tony Tang. So, continuing on here, this has been validated both against fractional flow reserve in 42 patients by Dr. Lockey and colleagues on the left, and against PET perfusion imaging. We have very good correlation with myocardial perfusion reserve by cardiac MRI. Some newer techniques allow us to perform 3D full volumetric coverage of the left ventricle so that we can actually see the perfusion throughout the entire left ventricle. And this is data from Dr. Magwani and colleagues, and they evaluated 35 patients with suspected coronary artery disease using quantitative coronary angiography as the gold standard, and they found really fantastic diagnostic performance for stress myocardial perfusion imaging, both using mid-diastole and end-systolic imaging. Utilizing the 3D volumetric coverage, we can actually create pixelated perfusion maps of the myocardium with fully quantitative assessment of the myocardial perfusion. So certainly we see that stress perfusion imaging has come a long way. The technology has advanced quite a bit. It's really remarkable what can be done with this technology. So the next question is, how useful is stress perfusion imaging? And first of all, for use in the emergency department or for assessment of patients with acute chest pain. Well, we know that stress CMR can really provide a comprehensive assessment of ischemic pathology. We can perform coronary MRA to look at coronary origins, anomalous coronary origins, or anomalous coronary course. Myocardial perfusion imaging, as we're describing. We can look at areas of myocardial edema using myocardial water-sensitive based imaging, such as T2-weighted imaging, and we can compare that to late enhancement to define area at risk. This is a lot of pioneering work by Dr. Matthias Friedrich, and so we can also assess high-risk features such as microvascular obstruction, right ventricular infarction in patients who've had an inferior MI, and of course left ventricular thrombus. So there's a lot of really comprehensive ischemic pathology we can assess. So Dr. Sven Plein and colleagues assessed the diagnostic performance of stress CMR in patients presenting with unstable angina to the emergency department, and utilizing QCA once again as the gold standard, found a phenomenal sensitivity and specificity. But more importantly, Dr. Inkenasorn and colleagues looked at the prognostic utility of stress perfusion CMR in the emergency department. And they looked at 135 patients presenting with acute chest pain and either low or borderline troponin. And for those patients who had a normal stress CMR, out to 3 years, they had 0 hard events. Versus when you compare that to patients who had a positive CMR, these patients had a substantial number of adverse outcomes. This is one other smaller but interesting study by Dr. Vogel-Clausen and colleagues that was performed at the National Institutes of Health in the United States. And they looked at 31 patients presenting to the emergency department with acute chest pain but normal cardiac enzymes. And all of these patients had both SPECT imaging and stress CMR. And interestingly, although it was low numbers, they found that a substantial portion, 30% of patients, had disease by CMR with a normal SPECT. And risk factors included diabetes and hypertension. Diabetes is a high-risk cohort that I'll speak about very briefly. But here we see two patients with a normal SPECT, patient A on the left, patient B on the right. But when we look at their stress perfusion images, we see that patient A has a substantial degree of myocardial perfusion defects consistent with 3-vessel disease. So this patient actually had a phenomenon of balanced ischemia, which is why he had a false negative nuclear perfusion image, versus the patient on the right indeed had normal stress CMR. The other advantage of utilizing stress CMR is you can assess for other causes of chest pain like pericardial disease, myocarditis, stress-induced apical cardiomyopathy or Takotsubo's disease, and hypertrophic cardiomyopathy. But what about cost effectiveness? One of the criticisms of stress CMR is that this is not a cost-effective modality. Well, this is one study by Dr. Miller and colleagues that was performed in Detroit, and they looked at 110 patients with chest pain who had moderate to high risk of having coronary artery disease, and patients were randomized to a strategy of either having a stress CMR or usual care in the ED. And we can see with the stress CMR strategy, almost 80% of patients were discharged immediately from the ED on same day of presentation, versus in the standard care arm, almost 70% were admitted for inpatient evaluation. At 30-day follow-up, both groups did very well. There were no events, but there was actually a median cost reduction of $580 per patient. And this doesn't seem very much, but this, interestingly, was almost the exact same amount found in the very large ROMACAT-2 study looking at the use of cardiac CT in the emergency department. Moving on to our larger and more robust population, those with stable coronary artery disease. There have been a number of studies looking at the sensitivity and specificity of both dobutamine and stress perfusion CMR. Don't worry, I'm not going to review all of these studies. The only study that I will briefly describe is the CE-MARC study. And CE-MARC was perhaps one of the most important studies done in the field of CMR. It was published by Dr. Greenwood and colleagues in the Lancet in 2012. And this was a prospective randomized diagnostic performance study with over 750 patients with stable angina, suspected coronary artery disease, who received both SPECT and CMR imaging. The gold standard was quantitative coronary angiography. And interestingly, the results of CMR found that CMR had both a very high sensitivity and very high specificity. In fact, the sensitivity was much higher than that for nuclear perfusion imaging. Now, CMARC has been criticized because a lot of nuclear imagers have suggested perhaps the nuclear perfusion imaging was not state-of-the-art. But very interestingly, the results of Core 320 were just published in the New England Journal a year and a half ago, and that was performed through a core lab at Johns Hopkins using state-of-the-art nuclear technology, and they found almost the exact same sensitivity. Finally, stress perfusion CMR has also been validated against the fractional flow reserve imaging, and here in 103 patients we see once again using an FFR of less than 0.75, both very high sensitivity and specificity. But although we've shown excellent diagnostic performance, as I alluded to earlier with the 8 years post-COURAGE trial, it's not just enough to show we have good diagnostic performance. We really have to assess the prognostic performance of these patients because that's what may ultimately modify care. And not only should we be evaluating the prognostic performance in all comers with chest pain symptomatology, but in particular we really have to assess high-risk cohorts such as diabetics, females, patients with obesity, and those patients with established coronary artery disease. And the reason that high-risk cohorts are of particular importance is that our standard techniques may lack sensitivity in these patients. So with nuclear perfusion imaging, we know we have soft tissue attenuation artifacts, we have a lower spatial resolution, we have the phenomenon of balanced ischemia. I showed you a case of that earlier in the talk. And of course, we have radiation exposure. With stress echocardiography, this is dependent on patient windows. There is reduced diagnostic performance when we have baseline wall motion abnormalities or left ventricular hypertrophy, or those patients with a reduced ejection fraction. And of course, the infravasal segment is often difficult to assess. Well, we know from all-comer data that those patients who have a normal nuclear perfusion scan have less than 1% annual risk of cardiac death. But this is a very interesting summary from one of the most prominent nuclear cardiologists in the world, Dr. Leslie Shaw. And she identified that there's actually substantial degree of data where even in the setting of a normal nuclear perfusion scan, the annual risk of cardiac death is actually substantially higher than 1%. So those patients who undergo a pharmacological rather than an exercise MPI, even in the setting of a normal study, have a 1.8 to 3.9% risk of annual cardiac death. That's in over 6,000 patients. Diabetics, particularly those who undergo pharmacological stress, 3.4% annual risk of cardiac death. And once again, even in patients with obesity, 1.7%. So substantially higher than 1%. So one of the questions we had is, what is the prognostic performance of stress perfusion CMR? And so we assessed over 800 patients who were referred for stress perfusion CMR to Brigham and Women's Hospital, where I performed my fellowship over a 10-year period. And over a 10-year period, none of these patients had an adverse event during stress CMR. 97% of the studies were diagnostic, and 1/3 of patients had established coronary artery disease prior to their stress perfusion CMR. And here we see the annual event rates stratified by either a positive stress perfusion CMR shown in red or a negative shown in blue. And interestingly, we find that those patients who had a negative stress perfusion CMR had very low annual event rates. But interestingly, even in the highest risk cohort, those with established coronary artery disease, a negative stress perfusion CMR portended a really excellent prognosis. And this is in comparison to those with a positive stress perfusion CMR who had very high annual event rates of cardiac death. Here we see the Kaplan-Meier analysis for all of our patients, stratified again in blue, negative stress perfusion CMR versus positive in red, and we see significant separation of the Kaplan-Meier curves for freedom from cardiac death and myocardial infarction. And once again, even in our highest risk subgroup, those with established coronary artery disease, we see significant separation of the Kaplan-Meier survival curves. So we performed a multivariable analysis to see if inducible ischemia by stress perfusion CMR was an independent predictor of cardiac death and myocardial infarction. And indeed, we found that not only was it an independent predictor, it was the strongest adjusted predictor of cardiac death and MI, including such variables as LV ejection fraction and resting ST abnormalities on the 12-lead electrocardiogram. In order to get a better assessment of what that hazard ratio means, we performed a net reclassification index. For those of you unfamiliar with net reclassification index, this is a more novel statistic that attempts to ascertain how helpful a novel biomarker is at the bedside in terms of risk stratifying patients across pre-established risk categories. So here we risk stratified our patients using our best overall clinical model that included ejection fraction, and patients were classified as either low risk, moderate risk, or high risk. And if we just concentrate on the moderate risk, those are patients who have, these are patients where we often have clinical equipoise, we see that the presence or absence of inducible ischemia reclassified over 90% of patients. 65% of patients were reclassified in green to low risk, and 25% of patients were reclassified in red to high risk. And then when we looked at the post-test event rates, the actual event rates in those reclassified patients, we find that the ones that were reclassified to low risk, extremely low risk over 3-year follow-up. Those patients at high risk were at very high risk over 3-year follow-up. So moving next to another very high-risk cohort, the patients with diabetics. We know that unfortunately 1 out of 10 adults in North America are diabetic. The vast majority of these patients have type 2 diabetes. There's been an overall 30% increase in the prevalence of diabetes over the past 10 years, particularly in children, which has lifelong implications. 60 to 75% of the mortality in diabetics is cardiac, and overall diabetes means a mean 7.5 years lower lifespan in men and 8.2 years in women. As I had alluded to earlier, SPECT and stress echo may have lower prognostic utility in diabetics due to balanced ischemia and those patients undergoing a pharmacological study. A lot of patients with diabetes cannot exercise due to peripheral vascular disease, peripheral neuropathy, and a substantial proportion of these patients have suffered silent ischemia or infarcts at the time of presentation. So here are a number of studies, both in SPECT, shown in pink, and in stress echo, shown in purple, with various large populations. And all of these patients had a normal study. And we see here the annual rates of cardiac death and myocardial infarction, even in the setting of a normal study, pharmacological study, were exceedingly high. They range from 1.9 to 6%. And when we examined the Berry 2D study, which was very similar to COURAGE, was actually published very shortly after the COURAGE study, and this was very analogous to COURAGE, over 2,300 patients with stable coronary artery disease and diabetes, randomized to optimal medical therapy versus revascularization. Similar to COURAGE, there was no difference in the treatment strategies, but particularly for those patients who underwent bypass, who had a much higher proportion of left main disease or 3-vessel, there was actually a reduction in cardiac death and myocardial infarction for those patients who underwent bypass surgery. So once again, this shows that risk stratifying based on prognosis is particularly important in diabetics. So we examined 173 diabetics consecutively referred for stress perfusion CMR with suspected ischemia. Almost half of these patients had inability to exercise. 1/3 had resting wall motion abnormalities at the time of their study. And 40%, almost half of these patients, had evidence of a prior infarct by late enhancement imaging. And once again, if we look at the annual event rates of cardiac death and MI stratified by those patients who had ischemia in red, those patients who had late enhancement in green, or those patients who had either no ischemia or late enhancement, once again, we see an almost graded increase in the annualized event rates. And in particular, for those patients who had neither ischemia or LGE, they enjoyed a very low annualized event rate of less than 1%. Now, this is small numbers, but it's very hypothesis generating. And once again, here we see the Kaplan-Meier analysis showing, again, significant separation based on the presence of ischemia, late enhancement, or the absence of either ischemia or late enhancement. We also looked at the degree of inducible ischemia based on A1C and found no significant correlation. Indeed, this is very in line with large prospective trials that have evaluated a more aggressive diabetic management strategy and have failed to actually find a reduction in events. But when we looked at duration of diabetes, we see an almost graded increase in the degree of myocardial ischemia. So here we see the results of our study. Again, this is hypothesis generating, but suggesting that stress CMR is able to identify a very low risk cohort amongst diabetics. Well, what about females? Females are another high risk subgroup. We know that coronary artery disease remains the leading cause of mortality in women. It's actually higher than cancer, including breast, chronic lower respiratory disease, Alzheimer's disease, and accidents combined. Females, unfortunately, suffer a higher mortality rate than men. The mortality rate, particularly in younger females, is twofold that of corresponding males. Females, unfortunately, have higher rates of angina and less obstructive coronary artery disease at the time of angiography. We're also getting quite worried about iatrogenic radiation exposure in particular females. This is data from 2 million patient members in large integrated healthcare systems in the US over a 15-year period. And if we look at the top 1% and top 10% of exposed iatrogenic radiation, we see an almost linear increase over this 15-year time period. And we have recent data suggesting that even one CT scan, 22 millisieverts of radiation, can increase the breast cancer risk by as much as 25 to 30%. So particularly with technologies such as SPECT, where there is iatrogenic radiation exposure, we're getting much more concerned. We also know that in SPECT imaging, the diagnostic performance is reduced in females due to a smaller chamber size, which impacts spatial resolution. So this is data from Dr. Coelho-Filho and colleagues in over 400 patients, and they looked at annual event rates of cardiac death and myocardial infarction in females, shown in pink, versus males, shown in green. And once again, those patients who have no inducible ischemia, the females have markedly low annual event rates, and there's no difference between females and males, and that's true for cardiac death and infarction, as well as cardiac death alone. And again, when we see the Kaplan-Meier survival curves, we see significant separation. And again, one thing I'd like to point out that's very interesting about this data is that the females tended to have much earlier separation than the males. Once again, in line with prior data showing that females may be at higher risk. Also in younger females, where there's concern about anomalous coronary arteries or anomalous coronary origins, we can also perform a coronary MRA in the same study and without any sort of radiation exposure, assess for anomalous coronary origins. The last high-risk subgroup I'd like to touch on is obesity. We know that already 35% of adults in North America are obese. This is estimated to reach over 50% of adults by 2030. There's a greater than 40% risk of cardiovascular death for every 5 kilogram per meter square increase of the BMI above 25, and a twofold increased risk of coronary artery disease. These patients often have a higher procedural risk of coronary intervention or bypass, and the cost of obesity alone in the United States is estimated at over $150 billion currently. This is estimated to reach $1 trillion per year by 2030. And in fact, the CDC just released last 6 months an emergency to the healthcare industry that the obesity epidemic threatens to reverse all our 30% reduction in cardiac death against atherosclerosis that we've had over the past 15 years. So this obesity epidemic is really worrisome. We know that imaging methods to detect coronary disease in obese patients can be quite challenging. Obese patients oftentimes cannot run on a treadmill. There's attenuation artifacts with nuclear perfusion imaging of the breast. Patients can have poor acoustic windows with stress echocardiography, reduced signal-to-noise ratio, and of course, a higher radiation dose with a higher body mass index. As I had described earlier, these patients, even in the setting of a normal nuclear perfusion scan, once again, may still remain at very high risk. So we looked at 285 patients who had a body mass index of greater than 30, once again referred for stress CMR with suspected myocardial ischemia. We examined the diagnostic feasibility. We found that in the majority of these patients, 83%, there were diagnostic studies where no sedation was even required. And when we looked at the proportion of patients who received sedation and had diagnostic studies, that was 94%, so the vast majority. Only 6% of patients actually had a non-diagnostic study. Once again, when we look at the event rates stratified by the presence of ischemia and late enhancement, we see an almost graded increase in annual event rates of cardiac death and MI. Whoops, and again, those patients who had neither late enhancement or myocardial ischemia had an excellent prognosis. So lastly, I'd just like to touch on a few slides about cost effectiveness with stress perfusion CMR. This is becoming particularly important in our recent economic climate. We have here US Medicare data showing the cost of all imaging, not just cardiac imaging, but already this has doubled from 2000 to 2006 and is well on track to actually exceed $25 billion by January 2016. This is data from the US alone. When we look at data from the Ontario Health Insurance Plan over a 10-year period, we see that despite the fact that the prevalence of acute myocardial infarction has remained relatively stable, there's been a marked increase in the utilization of imaging, including echocardiography, cardiac catheterization. And when we look at the attributable economic cost, we see that the vast majority of this cost is due to echocardiography and nuclear stress. Cardiac CT and cardiac MR barely even registers. And finally, we know that data from Dr. Patel and colleagues in New England Journal, they looked at almost 400,000 patients in the US that were referred for cardiac catheterization, and shockingly found that only about 38% of these patients had obstructive coronary artery disease, and the vast majority of these patients had actually undergone non-invasive testing. So, you know, patients are undergoing a test with procedural risk and cost and radiation with very low yield. So we performed a cost effectiveness analysis looking at cardiac MRI versus a comparator group at Mass General Hospital who underwent SPECT imaging. We propensity matched these patients based on Framingham risk score and Diamond-Forrester classification, found a very good match. And this slide is probably the most telling. Here we're looking at event rates, those patients who had either cardiac death or myocardial infarction. And when we look at those patients who had a negative SPECT or a negative CMR, we see the negative SPECT patients had far more events. And when we look at the patients who had a positive CMR or a positive SPECT, we see the SPECT patients had far fewer events. So once again, suggesting that CMR is giving us better risk stratification. And when we looked at the cost per quality adjusted life year, we found that actually there was a 30%, almost 20% cost per quality adjusted reduction with stress CMR versus SPECT imaging. And CE-MARC just released their prospective data and also found about a €30,000 per quality adjusted life year comparing stress CMR to SPECT imaging. Obviously, this data has our data was not prospective and also didn't adjust for some factors such as outpatient office visits. But once again, the cumulative data is suggesting that this is more cost-effective. The clinical utility of this has been reflected in a lot of international and national guidelines, where we're seeing stress CMR getting Class 2A and Class 1 recommendations. And lastly, I'd just like to suggest two paradigms where we utilize stress perfusion imaging, both where I perform my fellowship at Brigham and Women's Hospital and here at the Stephenson CMR Center. And that includes those patients who present with new heart failure. A stress CMR can often be extraordinarily helpful to the heart failure service. So the first thing is when we perform a stress CMR, we can evaluate for ischemia versus non-ischemia, and this can help determine those patients who need to undergo cardiac catheterization, who may have left main artery vessel disease, versus those patients who have a non-ischemic dilated cardiomyopathy. And in the same study, for those patients with a non-ischemic dilated cardiomyopathy, we can assess for infiltrative diseases, myocarditis, iron overload, or idiopathic dilated cardiomyopathy. But not only is this important from a diagnostic standpoint, it's also important from a prognostic standpoint. Those patients who have an ischemic cardiomyopathy, the absence or presence of late enhancement shows significant prognostic importance. We see here all-cause mortality based on either the presence or absence of late enhancement. This is from my prior supervisor, Dr. Raymond Huang. And for those patients with a non-ischemic dilated cardiomyopathy, the pattern of mid-wall fibrosis once again provides very important prognostic data. And lastly, from the electrophysiology group, those patients with new or unexplained arrhythmia, particularly those patients who have survived a cardiac arrest, once again, a stress CMR can be very helpful to our electrophysiology colleagues. Once again, with one study, we can assess for those patients who have potential myocardial ischemia as an etiological precipitant for their arrhythmia, thereby avoiding a cardiac catheterization. We can also look for other etiologies such as arrhythmogenic right ventricular cardiomyopathy, hypertrophic cardiomyopathy, infiltrative processes such as sarcoidosis, and of course fibrosis itself within the myocardium. And we are now having emerging data. We don't have the data yet, but we're working on it, looking at the prognostic potential of ischemia in these patients, but also the degree, extent, location of fibrosis. And this, of course, has significant implications because these patients, our electrophysiology colleagues, have to determine who should undergo very invasive and costly device implantation. Thank you so much for your time and attention. If you have any questions, I'd be happy to take them now.